Hi, I'm Mike Sughrue, Neurosurgeon, and welcome to Connectome of the Week. In this case, we're going to be reviewing this medial frontal partially butterflying glioblastoma. You can see that as we turn to the anatomic image, we note that this is a fairly extensive lesion that not only does it cross the midline at this portion here, but it's also sort of following two different pathways. So it is also, as you can see, pushing up and abutting this sort of thin medial cortex. Now, if we didn't know something about connectomics, we would think that there's nothing in there. It's too thin. How is it connected? But what connectomics can often teach us, and what imaging platforms like Quicktome can tell us, is actually there's a lot more in that little thin area than you think. Now, Quicktome is able to go in and define the definition of these boundaries and identify networks. And there are two big networks that we get concerned about in the medial frontal lobe. Now, one is the default mode network. So if we come here to the axial image, the default mode network has three parts: lateral parietal, posterior cingulate, and if we scroll up here, anterior cingulate. So it's a three-part network. And what we can tell on this right medial frontal montage is that the tumor basically, or the tracks basically terminate in the tumor. You can see this more clearly on the sagittal, where as we begin to scroll through the sagittal, you can see right there that the cancer has disconnected that part of the default mode network. And this makes it even more critical to at least preserve the other side, but also it would explain significant cognitive problems. In addition, we start looking at the salience network. The salience network is a middle cingulate and anterior insula network. So there's the middle cingulate part. And I'll go back to this image here. You can see that in that little rind that we would have normally thought couldn't possibly be doing anything is that little bit of the salience network. And there's the other part. Now the question is, do these even still connect to each other? Which is a valid question. Because what if the tumor is disconnected at like the default mode network? What you can see is the answer is no. They do talk to each other. And they actually talk to each other both in front of and behind the tumor. So again, artificial intelligence can pull out this relationship in a way the humans would struggle to. And so now what we know is that we're basically needing to at least remove the tumor down this way, staying underneath this network and in front of this portion of the frontal asinine tract in the back. You can see right there. Now, a third network that's in the area is the central executive network. And the CEN, if we go to the tab here, has really four parts: a frontal polar, a posterior frontal, a supramarginal, a posterior or inferior parietal lobe, and a little temporal area. If you scroll out on the sagittal, we'll see it here. Now, as we begin to look at this on the axial, you can see that this network is running on the lateral border. So in order to get into this tumor safely, a large portion of the risk is going to be entering and defining this lateral boundary, as well as this posterior and medial boundary with the salience network. Now, if we were to limit ourselves to just the corticospinal tract, we might be lured into a false sense of confidence, because the corticospinal tract is behind the tumor. You can see there's the core of the network. So it's not a motor region lesion, right? But the answer is three critical cognitive networks are running around the boundaries of this tumor. So in order to really do a minimally damaging operation for this patient, we need to first preserve the default mode network on the other side. You can see in Quicktome I can turn that on by doing that. So we need to not cut that little bundle, because that's what's connecting the default mode network to itself on the good side. You see that? The little cingulum bundle here in green. We need to preserve the salience network that's in the back. And you can see that also that thin rind of frontal lobe right there has function in it. Even though it looks like you wouldn't imagine that it would, it does. And so that's just, again, evidence that we can make patients worse by ignoring this. And you want to preserve as much of the central executive network as you can. So you want to make a cut here, preserve and be careful on this medial boundary. And then as you follow the tumor in towards the callosum, make sure you don't damage the default mode network. Thank you for joining us for this episode of Connectome of the Week.